Hello everyone. Welcome to a new episode of Specialty VMR. It'll be a clinical reasoning VMR with Dr. Gupta and Dr. DeCloux. And I'm Johan. I'm really happy to be here with you today. I just recently here that I matched. Really happy, really special day for me and for all the applicants. And we'll be really happy to moderate this case from Kushal. So, Dr. Gupta, do you want to introduce yourself?
Hi everyone, my name is Shaili Gupta. I work at the School of Medicine and the VA, which is an affiliate that serves the veterans of this country. I am an associate professor of medicine, but I also do ID, infectious diseases, so I serve on both services. I'm also an associate program director for the traditional internal medicine residency program. Nice to be here. Thank you. Corinne?
Hi, I'm Korynne. I'm one of the internal medicine PGY3s. I'm going to stay on and take one of the inpatient chief years soon. So I'm excited to be here. Thank you for inviting me.
Thank you so much. And we have two of our Academy members that will be scribing and doing teaching points at the end of the session. So I think Ethan will be scribing. Ethan, do you want to introduce yourself?
Hey everyone, my name is Ethan and part of the CQ Solver Academy. Congrats to all who participated in the match today. And very excited for the case today and excited for the discussion and learn from all of you.
Vijay, do you want to introduce yourself?
I'm Vijay from India. I'm one of the CP Solvers member. Super excited for the case and congratulations to everyone who matched.
So Kushal is supposed to present her case. She hasn't joined yet. She'll be a few minutes late, but I think Ethan will share the first aliquot on her behalf. So Ethan, do you want to start?
Yes. Tusha will be here in a minute, so I'll present for her now. So today we have a 83-year-old gentleman who is a traditional Chinese medicine practitioner presented with altered mental status and generalized weakness. And this is the first call.
So Dr. Gupta, do you want to tackle the first aliquot? So basically, it's an 83 years old male with altered mental status and generalized weakness.
Johan, Ethan, you muted out for a bit. I don't know if everyone else was hearing and I'm the only one who missed it. I heard that it was an 83-year-old man from China who practices Chinese medicine and presented with altered mental status. That's what I heard. Was
Yes,
that all that
exactly.
you said?
Exactly. And generalized weakness. Yes.
And generalized weakness. Sorry for fumbling here, but may I understand the structure, how this is done? I watched one video that you had shared on. Would Corinne go with the differential and then how do you want us to run this? Sorry, I'm not very familiar.
Okay, well, Dr. Gupta, do you have, for example, a framework for altered mental status and generalized weakness and how to tackle it?
Yes. Okay. So when someone presents with altered mental status, the first question that gets asked, and if you ask any neurologist, they would say it's a bogus term, because you're not really defining if this is delirium. Are you thinking it's dementia? Are you thinking that they have symptoms of encephalopathy? And then, of course, you can go through the mud piles if you do define that this is a delirium or confusional state, then the evaluation, of course, goes to the specific risk factors. Mud piles would be the M stands for metabolic states. So any kind of metabolic disorder, it can be electrolyte dysfunction, it can be hormonal dysfunction. If you have a COPD, a lot of this depends on the patient's prior medical history. So if you're finding someone with respiratory distress and they have COPD in the background, you would worry about hypercarbia and respiratory failure with respiratory acidosis. If it's a diabetic patient, you would worry about DKA. So these are all, again, ultimately they all fall into metabolic causes. We haven't even gone to the U yet. There's hypernatremia or hyponatremia can do it. Just pure hypoxemia can do it. In addition, you have to think about uremia, and then drugs and toxins for the D, which would be multiple different prescription medications, including psychiatric medications, but also substance use, especially alcohol. Infections like meningitis, encephalitis, any kind of systemic infection with generalized severe fever, especially in the elderly and the child, can cause altered mental status, even if it's not necessarily a brain infection. Korynne, do you want to jump in?
Yeah, I think that like covers a lot, like Dr. Gupta said, a lot of metabolic derangements can cause altered mental status. And then sometimes some people use a framework of like, primary CNS issues, whether that is, like I think Dr. Gupta touched upon meningitis, encephalitis. Within the primary CNS things, you can think of structural lesions, brain masses, metastases to the brain, abscesses, and then structural things like large, ischemic strokes or hemorrhagic strokes. And then other primary CNS lesions processes like seizures. And then kind of moving to non-primary CNS causes of altered mental status, like Dr. Gupta covered, any type of metabolic derangement, hypoglycemia, hypernatremia, elevated BUN and like renal failure. So all of those sort of metabolic derangements, hypercarbia, hypoxemia, like Dr. Gupta mentioned, and then, moving into like medications, right? Medications, any other sort of supplements that he may be taking that we may not know about kind of can cause this sort of altered mental status picture. So sort of, I like to break it down into like primary CNS and then kind of other parts of the body that can cause this. So, whether it's metabolic derangements, infections, medications the patient takes that might be interacting versus other toxins and supplements.
Yeah, and Elena's point is well taken that it doesn't have to be something that's inside the CNS. It could be something just generalized from other causes, which could be causing, especially because he's presenting with generalized weakness. So the whole point would be is this focal weakness, which would point more towards a CNS issue versus non-focal generalized weakness, which could be just from a storm, right? Any kind of inflammatory storm, interleukin storm from inflammation, infection, metabolic disorders would all cause that stormy picture that can lead to asthenia.
Yeah, and also like endocrinopathies, right? Like hyperthyroid, hypothyroid, things like that.
Well, great point. Ethan, do you want to go over the second aliquot?
Hey,
Yeah,
hi.
I think Kusho is here. I'll pass the mic to her.
Sorry, Dr. Gupta, for being late. That's a great discussion. I had a chance to just listen to you while we were discussing. So let me just give you a brief rest of the information as well as so the last normal we knew was the previous night. And that's because his friend who had actually knocked on his door that day morning saw that he hadn't really answered the call. And so she activated the EMS and they came and broke the door open, the fire department, and then they went in and saw that he was down. And he was also having an altered mental status. So she mentioned that she is not his POA, but his best friend. So she was just giving us more information. And he didn't really have any family in the US. So Yeah, so that's his neighbor, and according to her, his oral intake has been decreasing the past 2 months. And one day prior, he was not able to, he had visit, I mean, he was not able to move, and she helped him and asked him if she wanted to visit the doctor, and he didn't want to do that. So he was brought back to his bed, and she gave him some water and everything and then helped him with his day-to-day activities. But on the day of the admission, he was completely confused. And when he came in, he was complaining of pain in his urinary area. And he also had a slurred speech. And but his neighbor denied it. He takes Chinese medications, and his past medical history is of multiple strokes and Parkinson's disease, and no known drug allergies. And he denied any smoking, alcohol, and other drugs. And his neighbor mentioned that she's the one who's been giving him food, and wife and daughter are already passed away. And at his baseline, he walks independently, but has some chronic imbalance disturbances. Did you want me to give you the vitals as well, or did you want me to stop now for any kind of discussion?
I think we can stop now and have a little discussion and move forward to the vitals. One quick clarification, the oral intake was low for the last 2 days or 2 months?
2 months.
2 months. And it seems, I was under the impression that this case is residing in China, but no, the patient is in the US?
Yeah. He's in the US. He's in Chicago area. He's
Okay.
a Chinese in origin, and he also is a Chinese medicine practitioner. So all his medications which he's been taking has been only Chinese medicines. He has not done any allopathy medications, and his last labs which we know of, prior to the ones which I'm going to give you, are the ones which he had to do for immigration purposes, which was like more than 30 years ago. So he doesn't do anything with allopathy otherwise.
Okay. It's such a neat case. Okay, so there is mention for, and Korynne, please keep jumping in. There's mention for some urinary symptoms in like dysuria, right? Is he complaining of dysuria, or there's just when he says that there is pain in the urinary area?
Yeah, so he's just complaining of pain in his penile tip and then a lower abdomen.
I see. We don't know if he's had fever. Did the neighbor record that?
No.
2 months of anorexia, then in the last couple days, increasing weakness, and just found out that he also has pain in the urinary area. And
Yeah, so according to him, his speech is slurred, but his neighbor says that that's how he's been speaking. But patient mentions that he thinks his speech is slurred.
okay, and we don't know if the prior multiple strokes had caused speech slurring in the background at baseline. We don't know. Anything else we need to know, Korynne?
No, I agree. I think this is still a very interesting presentation, like with a very broad differential, right? Like the urinary pain in someone who is elderly makes you think of UTI, which definitely can cause altered mentation, generalized weakness, like perhaps a fall. Like we don't know why he ended up on the ground. Other things is electrolyte derangements. He's had poor PO intake, sounds like progressively for a while. He could have hypernatremia, he could have some renal failure, hyperkalemia. It sounds like we don't know how long he was on the ground. He could have, a bit of rhabdo, causing some muscle weakness. It's kind of unclear as to why he felt like he couldn't get off the ground. If that was focal, like Dr. Gupta said, did he have a stroke and then pass out? He thinks his speech is slurred, but it sounds like his neighbor doesn't think that's kind of the case. So I think this could be any of the things we talked about, right? From infectious to metabolic and electrolyte derangements to a primary, CNS issue, stroke, things like that. Hypoglycemia, if he's not been eating, could cause him to be altered and found down as well. So.
And as far as his history, like other history is concerned, I know you mentioned that he doesn't smoke. He doesn't smoke. But does he drink alcohol? Do we know what the alcohol intake is? Is there any other supplement or over-the-counter or herbal prep that he takes? Has he traveled recently?
Yeah, so he denies any alcohol, drugs, smoking, and he only for even for personal use, he does only Chinese medications, which would include the herbs, everything, whatever, everything it's inclusive of.
And is he able to provide history, or are we getting the history from the neighbor?
He talks, but then he thinks his speech is slurred. He's like a little bit confused, but then over time he was able to give us more information.
I see. Okay. And was he able to tell if he has taken any new herbal preparations recently, or is this his usual stuff that he takes?
Just the usual stuff.
Any mice in the house? Not that we know of. No animal exposures.
No, not that we know of.
Okay.
Is he taking any traditional herbs that we know of for Parkinson's disease? Like anything that would be dopaminergic?
Actually, none of the names were things which we knew of, and they were not labeled also. I mean, he seems to be having his own pharmacy kind of thing where he packs the medicines and he gives it to his patients. So there's just not proper labels for in his cabinet. And yeah.
Okay. So just to add, like other, we discussed the social, at least the substance use seems like that is not the case, but we still cannot be very sure about any other exposures. Is there possibility of carbon monoxide exposure? Is there possibility of bugs or ticks or mice? Everything could do a different kind of encephalitis and encephalopathy. Lymphocytic chorea meningitis can sometimes present exactly like this with, altered mental status, just generalized asthenia. Some slurred speech may show a little bit of focal deficit from that end. It doesn't necessarily have fever. That's one of the things about the LCM. And so just keeping that in mind, just the reason why I asked that question.
The other question I have before we go on to like vitals and physical exam is like a little more of his social history. So it sounds like his neighbor was checking in on him, but is he otherwise a very functional, healthy 83-year-old, or were there some concerns that he had some progressive decline over the last 2 months? Just trying to frame this as like, was this a super acute event in a not young, but otherwise healthy elderly male who was quite functional, or was there any concern from collateral that he had a decline? I'm thinking of things like, ADLs, IADLs, things like that, of how functional he was prior.
Yeah, so from our conversation, what we had with the neighbor and him, it sounds like she's also his patient. And so he still seems to be actively practicing his Chinese medicine. He's an active practitioner of it. It's not like he's retired from it. So I would presume, and we were under the impression there is some amount of normalcy in which he's been functioning, and this whole thing has happened. So she's a neighbor and his friend who found that he was not doing good over the past 2 months, so started offering to get him food and, taking care of him, giving him support. Does that make sense?
Yeah, that's helpful. And then the progressive, like, not eating part, how was that mentioned? Like, did he say, I'm just not hungry, or someone noticed he had been losing weight?
So I don't really understand. I mean, I don't really know how that happened, but then he used to cook for himself prior to the 2 months prior to that. And then for the 2 months, the neighbor was helping him out with it.
Okay, thank you. That's helpful.
We can go to the physical exam.
His vitals, like his body temperature was 36.4, and he required 2 liters of oxygen via nasal cannula, and his SpO2 was 95%. His heart rate was 114 per minute, and BP was 121/58 mmHg. And his weight was 50 kgs, height was 160 centimeters, and BMI was 20. He was confused oriented, time 2/4, and speaks both Chinese and English. So we elicited the history in English. And the neighbor was translating if there was any Chinese word in between. And we also used the translator. He had a dry tongue, dry skin, no edema, and his cranial nerves 2 to 12 were intact, and movement was his baseline in all the 4 extremities. There was a soft, mobile 2-centimeter mass in his left neck, and mild crackles was heard in the right lower lung, and irregular heart rhythm, and mild systolic murmur at the left lower sternal border. The abdomen was soft, non-tender, and no mass. And just the bladder area was, the bladder was palpable, so we did catheterize him too. Did you want me to give you labs, or did you want to? I think you're muted.
Yeah, I think we can discuss his physical exam.
The abdominal findings were there was suprapubic tenderness, right? Or no, there was no tenderness. It was just a full enlarged bladder.
Yeah, there was enlarged bladder. So, and then he was complaining of it, pain over there, but we couldn't elicit a tenderness.
Yeah, I think just starting with his vitals. So he is afebrile. His blood pressure is within a normal range, but he is tachycardic. And he's newly on oxygen, so he's hypoxic, I think, which is helpful to kind of framing kind of our initial kind of like paring down our differential, if you will. And I think some things that are concerning is this soft mobile mass in his neck. And he has crackles in his lower lungs, right? So one could think like that's fluid, but the physical exam, no, it's like dry tongue, dry skin, right? So he seems like volume down, which could be contributing to his tachycardia. And then as far as the hypoxemia, who knows how much this mass was like affecting his swallow. He could have aspirated, which could have led to kind of his constellations of symptoms and being altered. That's kind of what I took away from the physical exam. Seems to be a volume down guy who has this new finding of a neck mass and crackles in his right lower lung. And obviously the right lower lung is the most common place that elderly folks, right, aspirate into, just because of the angle of the right bronchus kind of is a more direct path for people to aspirate into.
Did they notice, I don't know if this, like if any of you actually saw this patient, but was there an exam finding on the eyes? Were the pupils dilated, for example? Was the skin color different?
He was like he didn't have any, pupils were not dilated, and then there was it was equally reacting to light, and it was normal, and there was no elicitable icterus either, and there were no rashes on his body or any tick bite. There was only a 2-centimeter soft mass on the right, on his neck, mobile mass on the left side of his neck, and crackles were there in the lungs.
Okay.
My other question, I think you mentioned it, but I'm not sure if it got transcribed, is you said alert and oriented times what? Like
2/4.
Sorry, just to clarify, was that like name and place, or what was he oriented to?
Yeah, he knew the name and place, but he wasn't really giving us the right information when it came to who's the president of the US, for instance.
And did you guys feel like when you talked to him, his speech was slurred, or did it seem intact?
It was like a person who's trying to find words, but we were attributing it to Parkinson's or probably previous stroke. But then he told us, so we wanted to find out if that was his baseline. And he said his speech is slurred. But then his neighbor was like, no, that's how he's been speaking. So that's where we had the whole discussion, whether that's his baseline or if there was a new change in his speech pattern.
Did the neighbor or the patient feel like he was having increased word finding difficulty, or was that seemingly also his baseline?
According to his neighbor, that's his baseline, but he told us that he thinks that he was having some slurred speech.
So just because we are going to continue talking about things even if they are unusual, but a few things that stand out that you could put in one basket, even though you're not giving other things, so it likely is not the case. But the dry skin, the dry tongue, the arrhythmia, the palpable bladder, which clearly is full and he's literally having pain but not being able to urinate, it seems like, the slurred speech and the confusion, those all could easily fall into anticholinergic poisoning. And there are some, like in India, of course, Vijay can relate to this. There is something called datura, and so it's the belladonna poisoning that presents like that. But similarly, there are herbal teas in China that can cause similar symptoms. But I felt that that got kind of put on the back burner when you said that the pupils were not dilated. It would be very unusual for someone to have anticholinergic poisoning and not have the pupils dilated. That's kind of goes very, very much against it. So that's why we probably don't need to consider that. The soft mass in the neck. See, part of this problem is, given this man has not seen any medical provider for the last 30 years or so, you may just be uncovering a whole bunch of chronic problems that he may have had, and you're just finding them now. So is it possible that he lives in atrial fibrillation, and maybe the irregular heart rate is from that? Did he actually have a stroke from the atrial fibrillation now? Is that what is happening now? As far as the mass in the left neck is concerned, he arrived in the US at least 30 years ago. I'm not sure how many times he's traveled outside the US. Is it possible that he may be having reactivation of tuberculosis? It would be unusual to have a neck like the scrofuloma kind of presentation where you have a neck node. That usually happens more in primary TB, where you're actually developing it at the site and the lymph node has gotten big and inflamed. But is it possible that someone develops tuberculous meningitis with encephalitis? He doesn't seem to have meningismus, so that kind of goes against it. Just thinking through all these things, could he have a malignancy that we're just diagnosing now? And is this all mm, symptoms from that? Should we go for labs, Korynne? Do you want to get more findings or something?
Yeah, that sounds good to me.
Okay.
So I thought it was an amazing discussion, especially about the dry skin and making a note of it, and as well as about the history of the herbal teas. And so for the labs, the WBC was 11.1, hemoglobin was 17.3, platelet was 156. It was neutrophil predominant at 89.4. And CK was 364, troponin was 0.23, TSH was 1.54, T4 was 1. In serum electrolytes, sodium was 149, and potassium was 4.3, bicarb was 19. In LFT, alk-phos was 62, AST 47, ALT 19, and RFT BUN was 56, creatinine was 1.26, his glucose was 61, EGFR was more than 60. And and his total bilirubin was 2.5, and anion gap was 24, ammonia level was 34, Beta hydroxybutyrate was 5.10, lactate levels was 2.4, and lipase was less than 4. Magnesium was 2.3. So shall I give you the urine as well?
So the beta hydroxybutyrate, this is an elevated level, right?
Yes.
Okay.
The urine, the color was dark yellow. It was cloudy in appearance. pH was 6. Moderate amount of bilirubin. Ketones was 40, which is large. And then blood was large amount. Protein was 30. Nitrite and leukocyte esterase were negative. WBC was 40 to 50. And RBC 5 to 10, bacteria 2+, and squamous epithelial cells 0 to 3.
Okay.
Did you want me to do anything further? The chest X-ray read, ECG read, or did you want to discuss this, Dr. Gupta?
We can discuss this next part. So he's, hypernatremic, which is like consistent sort of with the story of decreased PO intake and his dry mucous membranes on exam. But he also has like, an anion gap metabolic acidosis. So all of those mud piles, things that Dr. Gupta went through, it looks like he has a marginally elevated lactate as well as an elevated beta hydroxybutyrate, likely some, element of starvation ketosis, which is not shocking, I think, considering how high his sodium is, which both could be contributing to his anion gap of 24. Yeah, and I'll let Dr. Gupta comment.
Yeah, I wonder if this man could is it possible that he is a diabetic? He almost presents like a hypoglycemic ketosis, starvation ketosis kind of picture. This is more likely just starvation ketosis, but he does have, there was something that I saw that made me wonder if he also is a diabetic in the background. Is it possible that he's just been treating himself with medications and maybe overdid something of an hypoglycemic that's herbal? So I would wonder if this is just starvation ketosis versus herbal medication-induced hypoglycemic ketosis.
Yeah, and he had ketones in his urine, right, which is
I think
consistent
so.
with.
I was looking for that, but I don't see it now. Oh yeah, there it is.
Oh, yeah,
Okay, yeah.
The other
Yeah.
interesting thing that jumped out in his urine, and we can kind of talk about this further, is that he had a large amount of blood, but only 5 to 10 RBCs, right? So that makes you think of other, and he had bilirubin in his urine, makes you kind of think of other things other than just urinating out blood, right? Like myoglobin. I know his CK was high, but not that high, right? It wasn't in the thousands.
Yeah, and his serum bili is a little high too. Direct bilirubinemia can occur just from, depending on what your genetics are, you could just do that by a huge amount of stress, and that can just start raising it. Sepsis can do it, acidosis can do it. So just isolated direct bilirubinemia does not necessarily, it doesn't mean anything to do with liver. The AST was a little bit high, but so was the CK, so that's probably just a muscle source for the AST, not the liver source. I still don't know how to tie the one positive finding that we didn't have an explanation for, which was the mass in the left neck. I had a follow-up question regarding that mass. Is it tender, inflamed, red, pustulating, discharge? Is it tethered to the neck muscle?
So it was not inflamed, or it was not a pustule or infectious, but then it was mobile, and there was just, and it was soft in the side of the neck, and it was like at the posterior triangle of the neck. It's behind the sternoclavicular.
Okay, that's a pretty large one. 2 centimeter is a good size for a lymph node there. There was no other lymphadenopathy that you found on his entire exam. Okay. Okay, so trying to narrow down some of the differential here. I would still keep some kind of ingestion in the picture. I think we need more studies to be done to really figure out his neurological status. So likely we'll need something more than just the neuro exam was reassuring, but it's not quite clear what is going on there. He does seem to have acidosis. Nothing is as remarkable on his labs to suggest the degree of presentation, the clinical presentation. Definitely doesn't explain the irregular heart rhythm, for example. But you would want to start management while you're starting to do other workup. Like the man is clearly very, very dehydrated and hypoglycemic. So I would start him on some fluids. I would be cautious because he already seems to have some crackles in the lungs. I'm not sure if that's fluid versus pneumonia, but he had it there. Is it possible that he aspirated? We don't know. So, and because we don't know his past history, does he have CHF in the background? So I would just be cautious about giving him fluid and give him gentle fluids. Korynne, what would you want next?
As far as like studies, like
Yeah.
imaging. Yeah, I don't know. I think probably some of the stuff that's listed there, right? Like you'd get an EKG. It sounds like his heart rate's irregular to see if he's in, AFib or some other arrhythmia to make sure there's no other concerning EKG changes. Chest X-ray because he has those right lower crackles. I know some people in the chat said CT of the head. He's non-focal, but I don't think it's a wrong idea, especially with his past history of stroke and he was found down. Yeah, things like that.
So his ECG, I'm just going to give the final read. There was an irregular rate, and the rhythm was irregular, and no acute changes in the T waves or ST elevation. And yeah.
So what was the rhythm then? Was it?
It was like more like AFib.
Okay.
And then that he did have irregular heart rhythm even during auscultation and his pulse, so that kind of like coincided with that. And his chest X-ray read was there was a calcification in the arch of the aorta, ascending aorta with increased bronchovascular markings in bilateral lungs, right more than he left, and that was his chest X-ray read. So we did get a cardiac echo. And like you mentioned, we were managing the patient while we were getting all these investigations. But so the cardiac echo did show that he had a severe left ventricular hypertrophy. His ejection fraction was 80% hyperdynamic with the grade 1 diastolic dysfunction with mild AR, trivial MR, and mild TR. Did you want me to share the CT of the head now, or did you want to discuss anything before we did that?
I think we can discuss a little bit here. So it sounds like he does have a infiltrate bilaterally right lower than left, which is not surprising given the physical exam. And as far as his echo, his EF's super high, right? Because he's sort of in a hyperdynamic, like he's tachycardic, presumably at the time that they got this, sort of in a higher output state, right? So it's possible that he has like severe hypovolemia. He has a little bit of a anion gap acidosis. So, it's possible that infection's contributing. I know his white count was like very mildly elevated in neutrophilic predominance. So those are the things in my mind, sort of high output state, either, severe hypovolemia where his physical exam with the dry mucous membranes kind of go along with that. His hypernatremia goes along with that. He's in some starvation ketosis, but has also, like I said, a mild lactate elevation. So the bilateral infiltrate makes me think of some sort of potentially, pneumonia versus aspiration process.
He's a very, very dry man for sure. Needs a lot of fluid resuscitation. So at this time, if you are noticing that as, I mean, the bronchovascular infiltration, I'm not sure how much, clearly, if he's that dry, it would be unusual for him to have that degree of pulmonary vascular edema, especially given his overall echo findings. So I would think, yeah, likely is pneumonia. Would you like to start antibiotics for him at the same time?
To be honest, probably someone who comes from the ED like this is going to get both volume resuscitated and started on empiric antibiotics. So yeah.
Okay. The alternate mental status with the pneumonia, the only other thing that we worry about is there a CNS component at the same time? So like pneumococcus, you want to make sure that there is no meningismus. He does not have fever. He does not have any leukocytosis, no meningeal findings at all. So I don't think we're worried about meningitis at this time. Okay, this is CT head.
Yeah, so this is
Yeah.
the CT head which we got. And did you want me to give the final read for this, Dr. Gupta? Or
Yes, please.
Yeah, okay. So the CT had it was diffusely atrophic with moderate chronic microvascular ischemic disease, chronic lacunar infarcts in bilateral ganglio-capsular regions, right pons and left cerebellum, and multiple small lucencies seen within the bones. Multiple myeloma or metastatic disease is not excluded. And then, oh, so sorry. And then we did get a CT of the chest as well. And this was what we had on the CT of the chest. The final reads for the CT of the chest was with a tree and bud configuration in the left lower lobe, findings concerning for an infectious etiology, moderate atherosclerosis in the aorta, mild hyperplasia of the bilateral adrenal glands, no hydronephrosis or hydroureter, liver, gallbladder, pancreas, spleen, bowel, unremarkable, low lymphadenopathy is evident.
So by the time the CAT scan was done, did they had put a Foley in place then? The bladder was read as normal. Okay. And I'm assuming he had a large volume.
Yeah, we drained about through the catheter after we put about 1.5 liters, 1.5 liters.
Okay. Can we get a calcium level on him? Do we have that?
Yeah, so his calcium was a 9.4.
And with the albumin, or like, do we know his corrected picture?
Yeah, so his
Correct.
albumin is 3.7.
Okay. So it's still within the normal range. All right, so we have these punched out round lesions in the skull. We still have that neck mass. And then we have this pulmonary picture. Is it a chronic versus acute on chronic infection? Along with likely chronic versus acute on chronic presentation of an AFib in a very dry man.
Yeah, and I saw some folks commenting on the train bud in the chat, and like it is somewhat, it's interesting when you see it, it's somewhat non-specific, can be viral, bacterial. A lot of times when people see that, they think atypical infections like non-TB mycoplasma can cause tree and bud. Different fungal infections can cause sort of a tree and bud appearance.
So, Dr. Gupta and Korynne, well, do you have maybe a final diagnosis? I guess it's the last aliquot before the diagnosis, right, Kushal?
Yes. I could give you
Yes.
some more information if you needed something, especially since you had mentioned like about the lump in the neck and there were lytic lesions in the bone, skull bone. We just went back and tried to examine him again and make sure we did a thorough exam. And so we did do a PR for him. His prostate was enlarged, and then his breast on the left side more than right there was more of a fullness which was present, but there was no discharge and no axillary lymph nodes either.
I mean, so a couple other things. So the calcium being a little bit high, the lytic bone lesions not necessarily would tie up with this, but potentially could. The nodular lesion, the tree in bud appearance in the lung, is it possible that he has sarcoidosis? That's another thing that comes to mind. But the punched out lesions are really, really remarkable and very diagnostic of multiple myeloma. That's the usual cause for those. I just don't know how to explain the left neck mass in that case necessarily.
Korynne, you're mute.
Oop, sorry, I didn't mean that. So I was like, this may be a reach, but like Langerhans cell histiocytosis can also cause like lytic bone lesions. It can cause like neck lumps. It can cause diabetes insipidus, right? So you could become volume depleted. I don't know. That's one possible differential.
Yeah, it can cause this kind of CNS storm kind of presentation too with altered mental status. Prostate mets would be more osteoblastic. This is more osteolytic, you said, right? It was a lytic kind of appearance. So if this was prostate CA, likely won't explain the lytic lesions in the skull. So when I think of the neck mass, I'm thinking of something related to lungs and neck, right? So every single time I think to the granulomatous disorders, I go for sarcoidosis, I go for tuberculosis. Those are the two main ones that I think of. But then neither of those really tie up very, very well to the very well-defined lytic bone lesions that you're describing, especially in the skull. That's a very kind of picture. So that's why we're kind of not very sure. You tell us what it is.
So we were very our top differentials were the ones which people have mentioned, and you were mentioning about. It could be either multiple myeloma or a granulomatous lesion, or we were also wondering if the breast mass, like, just because after we found that and we found some fullness, but we just didn't know if it was a normal variable because a normal variant, because the patient was like, no, that's how it's always been. And but the thing
he had a breast mass.
Breast fullness in his left side more than the right side. But then I don't really know if that's something we found because we were searching for something and to tie up with the lytic lesions in the brain. But the patient was like, that's how it's always really been. And it's not new. And but the thing is, like, after this, the patient was not cooperative or didn't really want allopathic treatment. And so we didn't really know what the primary tumor was, but we just knew there was a lytic lesions in his brain, and most likely it was a secondary, it's either metastasis or multiple myeloma. And so he was agreeable for getting antibiotics treatment, and he tested negative for COVID. And since he communicated very strongly that he didn't want to be investigated further in terms of having a biopsy we didn't proceed with that to find that out, especially since his age was also 83, and so we gave it up to him to make a decision as to how he wanted to proceed with it. So as of now, he is doing better in terms of after the antibiotics, he did become better, and then with his fluids correction, and he opted for an hospice care if that's what was required, but he didn't really want to be poked with needles anymore in terms of tissue being taken for finding out what the primary is.
Do you know what antibiotics helped?
So sorry, I muted myself. So we did give him Piptas, and we also gave him vancomycin, and that's what we had started him off with. And he, after seeing the tree in bud appearance, we did send out for beta-D-glucan to see if it could be any fungal infection, because especially since he was diabetic, I mean, his beta-hydroxybutyrate was very high, and we didn't really know if it was, they could be more prone for any fungal infection. But it came back negative, so we were wondering if that was also, if it was due to either viral or non-tuberculous mycobacteria. So yeah.
Okay. It just reminded me of a case which there was I'll just share it because you have time now, right? We're done with the case.
So it was the last the diagnosis which we had was he was having a diabetic ketoacidosis or starvation ketoacidosis and sepsis, and also lytic lesions in the brain, either due to multiple myeloma or unknown primary.
Okay, great. This case reminded me of a similar patient that we had seen. It was an 87-year-old man who had been treated as unknown primary with lytic lesions in the bones, assumed to have malignancy, and had actually already been started on chemotherapy in an outside hospital. Came into us with altered mental status, had lung findings, and in his case, he had a lung abscess. So I got very suspicious for nocardia. We scanned his brain. He had a brain abscess. We sampled it. It was all nocardia. Then we found out that what was being thought of this tumor as like all different lesions were all actually nocardial abscesses in his body, including the bones. And he responded beautifully to antibiotics and was out of the hospital. So sometimes, infections can present as big disguised things, can often be confused for other serious entities like malignancy. Not saying that this particular case had that, because he didn't have those specific findings. But yeah, masquerades.
Yeah, kind of like Dr. Gupta said, I know you sent just the beta-D-glucan, but like lots of different fungal infections can cause like lytic bone lesions, right? If you get like osteo, you can get like fungal osteo with lytic bone lesions, which is interesting.
Yeah, I'm not sure I would have called him septic though, because he did not have the SIRS criteria. There's like I couldn't satisfy his overall presentation and classify it as sepsis at all. But I guess for the mild pneumonic findings that you had, it was okay to give him the antibiotics that he got. But I would just have called it ketoacidosis and unknown primary with these lesions, and probably would have pushed him to work up more, but people make their choices and that's fine. This was a good case. Thank you for sharing with us.
Thank you so much for your discussion, Dr. Gupta. And I think like in our hospital, like if the lactate levels is more than 2, then we just try being a lot more precautionary measures, because our patient population is older and he had 2.4. So we just, yeah.
Yeah.
Wow, thank you so much, Kushal, for this amazing case. And thank you, Dr. Gupta and Dr. DeCloux for discussing. Now Vijay will go over the teaching points and we will close the session.
So this is a very interesting case of an elderly gentleman who presented primarily with altered mental status. So we saw an approach to altered mental status wherein it could be a primary CNS lesion, which could be a space occupying lesion, structural lesion, stroke or seizures, or metabolic causes, drugs, infections or endocrinopathies. And this patient also presented with weakness, so it was important to characterize this weakness as being objective or subjective. And the coexisting slurring made us think of possibilities of a primary CNS causes like seizure or stroke, and the time course being very essential as the patient also had reduced intake of food since the past 2 months. So time course is essential in any neurological illness to characterize it as an acute or a chronic or an acute and chronic process. And because it is an acute onset illness and in an elderly altered mental status, uh, infections can mimic altered mental status without having frank evidence of fevers. So it is important to look for exposures, whether it is indoor, and looking for relevant exposures in the form of bugs, ticks, mites, or any toxins. And also some rare exposures like carbon monoxide poisoning. And coming to the examination that revealed patient completely dry in the terms of dry neck, skin, and a palpable bladder, which is consistent with a anticholinergic toxidrome. So it is essential to think of a toxidrome as well, which was commonly datura or some herbal medications could cause all of this. And the relevant labs showed a high anion gap metabolic acidosis. In the presence of patient being dry, the possibilities were considered of starvation or drug-induced and an elevated lactate. So all of this would suggest an infection and a coexisting ketoacidosis. And given the irregular heart rate and an atrial fibrillation, the echo showed a hyperdynamic EF of 70%, so which could be mainly due to hypovolemia or high output cardiac states. And a CT that showed a treen bud nodules. So treen bud nodules are very non-specific. It could be viral, it could be atypical infections, or rarely fungal infections and granulomatous lesion. And in further evaluation, patient was noted to have lytic bone lesions and also on examination had a left neck mass. So combining these two, it could be possibilities of myeloma, metastasis, and Langerhans histiocytosis were thought of. Rarely, it could be also due to granulomatous lesions like endemic mycosis, like blasto. Also, the patient had borderline, there is a teaching pearl that was suggested whenever we have lytic lesions, so possibilities of paraproteinemias. And paraproteinemias can cause elevated ammonia as well. So this is one thing that we have to keep in mind. And although we can consider lytic lesion as neoplasms, there could be rare instances where infection could masquerade neoplasms, especially like nocardia. So the final diagnosis we had was a patient with sepsis and suspected myeloma or primary cancer of unknown origin and a sepsis.
Wow, thank you so much, Vijay, and thank you everyone for tuning in. Thank you, Dr. Gupta and Dr. DeCloux again for joining, and see you next time. Bye.
Thank you.